I'm here with Dr. David Cameron, who is the CMO of Hent Health, among other things, but that's the reason we're here today. So,
Spencer, thanks so much for having me here. I am the Chief Medical Officer at Hent Connect. It's an organization where we're trying to build a network of direct primary care. And what direct primary care is, instead of fee-for-service primary care, it is a membership base. And so the fee structure is different. So either the patient or the employer is paying a monthly fee for a set number of primary care services. And you can think of it kind of like, almost like a gym membership. You pay a monthly fee for your gym membership and you can go as much as you want. It's unlimited.
Okay.
And with the primary care, you're able to do primary care, urgent care, all the chronic disease management. But we also promise the same day, next day appointments, the coordination of care to specialty and hospital care. But we also keep our cell phones on 24/7 so our patients can get a hold of us anytime. Right now, they can call me, and I'll probably ignore them for
I'm in a podcast. Hold on, I'll get back to you about that hurt ankle, right?
I heard about direct primary care at a talk. It was 2011. I heard a talk. It was in our county medical society. Garrison Bliss, who's one of the founders of direct primary care, gave a talk, and immediately I knew, like, I don't know what I need to do, but I want to do that. That's what I want to do. 6 months later, I started chatting with DaVita, and they were interested in starting up a direct primary care system for all of their employees across the country.
Okay.
And I said, well, let's talk about that.
Yeah.
And so I joined up with 5 other business folk at DaVita, and we built the first direct primary care clinic in Tacoma, Washington. And there was the financial headquarters just down the street. And so we built it there right near, and we set it up so that we could take care of all of their employees and their dependents. But those patients, they would come and they would see me for all of their healthcare needs. And that was including primary care. There's, if they have diabetes, high blood pressure, if they needed procedures, lumps and bumps, freeze, warts, all of that stuff. Took care of the pediatrics, do the wellness exams. We drew blood in the clinic, sent people just down the street to get x-rays at the most cost-effective places. And we had our referral networks to refer to the orthopedic surgeons that had their own ambulatory surgical centers. So we could really help. And I knew their benefit plan inside and out. So I could tell them, I said, hey, your deductible is this. This is going to be your co-insurance if you go outside of here. And I'd give them options. I'd say, hey, where would you like to go? There's 5 different places where you can get your MRI. If I send you to this one place, it's $400. If I send you to this other place, it's $3,000. And they said, well, maybe I'll go to the one that's $400.
Yeah. I mean, I was telling you earlier, you almost effectively act as a consultant for them, not guiding or steering them. You have to go here, you have to go here. You say, here are your options.
Right.
Based on the options you have, here are your choices. Which choice seems like the smarter choice? And then you let them make that choice.
Yeah, I feel like I'm their consultant.
Yeah.
I think patients are smart. And if I present them a bunch of choices that could get them into the same place, and I can talk about the pros and the cons of each of the different options, I have a feeling that patients are good at arriving at what meets their values. And I like to respect patients' goals and their values. And it might be different from patient to patient. But I think that they can make some very good decisions if you have the time to be able to have those discussions.
Yeah. So this is a monthly fee based on what is it? Is it different prices for if it's an employee only or family, different price points for that?
Yeah,
correct?
And adults are typically with a network of direct primary care. On average, it's around $75 to $85 for adults and about $40 to $50 per month for kids.
Okay. So if I'm an employer listening to this, why would I consider this model? What are some of the most compelling arguments of why you would want to abandon the fee-for-service model for your population and get them on DPC?
Yeah, well, I think employers are interested in the triple aim, making sure there's cost, quality, and customer satisfaction. I think the quality and customer satisfaction are very easy to demonstrate. There have been some studies that have been done with cost. The Milliman study that came out a couple years ago took a look at an employer that was self-funded, had 2,000 lives that were on the plan. And they gave them the option. They said, hey, you can do direct primary care or you can do the fee-for-service PPO option. And they took a look after the year. I think they would risk stratify them, risk adjust, and then lop off the outliers, and took a look at total healthcare spend to the plan at the end of the year after 12 months. And there was a 40% reduction in emergency room use with the direct primary care compared to the fee for service. And actually, that's not surprising. On Monday, 8 o'clock, 9 o'clock at night, I had a patient call me up. His 20-year-old that was on a skateboard. He fell, injured his foot. It was really swollen, very bruised, couldn't put any weight on it. And he was like, hey, I know you tell me that I always have to call. I want you tell me that I want him to call me first before going to emergency room, urgent care, because 9 times out of 10, I can take care of it. And he said, I'm just doing that, but I'm on my way to the emergency room. And I said, okay, well, before you do that, let me just, and I asked him the questions, any numbness, how's the pain level? Is there any cold temperature? I just want to make sure there was nothing there that was an emergency. And there wasn't. And so I said, well, you can for sure go to the emergency room, but that's going to be an automatic $3,000 bill. What we could do as an option is I could give you some pain medicines and you could just rest tonight. I mean, do you think we can get this pain under control? And I'll get you in. I've got the cash bundled price at our orthopedic guy, and it's $200 for the x-ray and the visit and the treatment, all in one. But it's whatever you want to do. And he's like, oh, well, I think if you called in some medicines, I could just ice it and just stay in bed and then wait till the morning. It would be another 10 hours. And so he decided to do that. Got the x-ray. Actually, it wasn't fractured.
Wasn't even fractured.
Wasn't even fractured. Okay. Probably a really bad sprain.
Yeah.
Put him in a boot, and I chatted with him a couple days ago, and he was doing okay. I mean, he's still pretty sore, but he was doing okay. We're going to repeat the x-ray just in case there might have been just some weight. He couldn't do weight-bearing x-rays, but we're going to do a repeat x-ray next week, weight-bearing, just to make sure there's nothing that we're missing or any severe ligament damage. But this is the type of care that you get. If that patient was in fee for service, they would probably call the hospital triage center and they would say, "Ooh, that's worrisome for for a fracture. You should go to the emergency room. Right. Urgent cares are closed. You should go to the emergency room." And And I had another patient that was 37 years old a few weeks ago, and very, very anxious person, and I know her very well. And she called and she thought she was having a heart attack. And I asked her all the questions. It was clear that it was a panic attack. And she was thinking about going to the emergency room. So I said, okay, we're just gonna talk. We're gonna talk you through this thing. After 15 minutes, the panic attack went away, as expected, and she felt a ton better. We adjusted her medicines. I saw her the next day, did an EKG, made sure that we weren't missing anything, and that would have probably been about a $4,000 ER bill. And I think she had a low deductible plan, so that would have probably hit the plan pretty hard. So it's not surprising when you have patients that are educated to contact their personal doctor who knows them well, that they access this. You have a significant reduction in ER visits. But we also have a significant reduction in inpatient visits as well, because if we're taking better care of their chronic conditions, 85% of spend is chronic conditions and the subsequent problems and surgeries and hospitalizations from chronic conditions. So if we can have those optimally managed, so 20% reduction in inpatient hospitalization is not unusual. And after 1 year, we find that employers typically save money, but the studies have not yet been done for the 2 and the 3. But our employers always say that their cost goes down significantly by year 2 and year 3. But the problem with year 1 is that a lot of patients come to us and they haven't had their colonoscopy, haven't had their mammogram or pap smear. So we end up doing all these preventive things, which add cost to the plan for the short term. But then once they've been in the system for 2, 3, that's when we usually get the 20 to 25% reduction in spend.
Yeah.